Ladies and gentlemen, we're going to start the program, and we are now opening the chemotherapy session. I'm going to give the first talk on this session, and my title of my lecture is the Evaluation of Breast Specimens After Neoadjuvant Chemotherapy. Neoadjuvant chemotherapy now is the standard of care for locally advanced breast carcinoma, including inflammatory breast cancer. Application of neoadjuvant chemotherapy allows downstaging of the large inoperable breast carcinoma, permitting the surgical resection, and it also allows us to evaluate the effect of chemotherapy in vivo, making us information about the effect of chemotherapy. Before we start neoadjuvant chemotherapy, there are a couple of things that we have to make sure that the patient has before the neoadjuvant chemotherapy. Pre-treatment core needle biopsy must be adequate. This is a very important aspect of neoadjuvant chemotherapy. The core needle biopsy should be adequate not only to establish the diagnosis of carcinoma, but to establish the invasiveness of the tumor, and the core needle biopsy has to be adequate for evaluation of all prognostic markers. So clinically, having a large tumor and having an FNA diagnosis of carcinoma is not adequate for initiation of neoadjuvant chemotherapy. And core needle biopsy has to be large enough to establish all the established prognostic markers, including histologic type and grade, and the evaluation of the biomarkers. If there are more than multiple foci of tumors based on imaging or based on clinical presentation, these different foci have to be biopsied to establish the extent of the lesion. And if the axillary lymph nodes are palpable or they are suspicious under the ultrasound, they also need to be evaluated to make sure that we establish the stage of the lesion before we initiate the neoadjuvant chemotherapy. So we routinely perform axillary ultrasound on all these patients with locally advanced breast carcinoma. Application of sentinel lymph nodes before neoadjuvant chemotherapy is a controversial issue. In MD Anderson Cancer Center, where I practice, we do not perform sentinel lymph nodes prior to neoadjuvant chemotherapy, but there are some centers this has been practiced. Handling of the specimen neoadjuvant chemotherapy is one of the most critical steps. And gross assessment of the specimen is very important. And as a pathologist, I spent a lot of time, predominantly most of my time, to really evaluate these specimens grossly and identify the tumor bed. And for this, a multidisciplinary approach with close clinical and radiologic evaluation and performing the maps of the specimens is really very important, and I would like to demonstrate some of these. To achieve this multidisciplinary collaboration, it's essential that the surgical form request should contain the adequately detailed information. And access to images, particularly MRI scans, if they are available at the time of specimen dissection, is extremely important. In order to demonstrate this, I would like to present a case. This is a 38-year-old female presented with a 2.5 centimeter palpable breast mass, and physical examination revealed prominent axillary lymph node. She had a core needle biopsy of the breast and final aspiration of the axillary lymph node. Her breast biopsy showed invasive high-grade ductal carcinoma, and the axillary FNA was positive for metastatic breast carcinoma. With this information and based on her clinical evaluation, she has a stage 3 lesion because she has 2.5 centimeter mass, and her expected survival is approximately 40%. The patient underwent neoadjuvant chemotherapy. Clinically, her mass became softer during her chemotherapy and smaller. Lymph nodes were no longer palpable after the first chemotherapy. And MRI showed complete resolution of her mass after the third chemotherapy, and she underwent an excision of breast mass and complete axillary lymph node dissection. This is her MRI scan prior to chemotherapy. Here is the 2.5 centimeter mass adjacent to a well-circumscribed nodule. This was also biopsied, and this is invasive ductal carcinoma, and this lesion is fibroadenoma. And after completion of her chemotherapy, the tumor is completely disappeared on MRI, and you can still see the fibroadenoma unchanged. And she underwent a segmental resection, and here is the biopsy clip associated with her invasive carcinoma. And in that specimen, the surgeon was able to remove the fibroadenoma also. Here is the fibroadenoma, and this is where we would call residual fibrous tumor bed. And here is what the fibrous tumor bed looks like. This dense gray-white area adjacent to adipose tissue. And by looking at this grossly, we really cannot, as a pathologist, we cannot definitely say if there is any residual tumor in this fibrous area or not. So in terms of microscopic evaluation, our sections, this area needs to be submitted for evaluation. And when we submitted this area, the tumor bed consists of an area of histiocytes and lymphocytes. No residual carcinoma was identified. Since she had a positive axillary lymph node, she underwent completion axillary node dissection. 16 lymph nodes were excised, and all the lymph nodes were negative for metastatic carcinoma. And this is her tumor bed. Looks like this fibrous area corresponding that gray-white area that we saw on gross evaluation. There were areas of microcalcification, but no residual carcinoma. So with that, now she is stage 0, and her expected survival is 90%. So to receive this information that she had a very poor prognostic category tumor to a good prognostic category tumor now is very important in terms of her management. And this is one of the most important aspect of neoadjuvant chemotherapy, that we can give this information to the patient immediately as opposed to waiting years and years, and waiting if she is going to develop metastatic carcinoma or not. So this is really very important. So based on this, neoadjuvant chemotherapy is now standard therapy for all locally advanced breast carcinoma. And in the United States, it is increasingly used for earlier stage of operable breast cancer. After neoadjuvant chemotherapy, we see a wide range of pathologic changes. And as pathologists, we have to be very familiar with these and how to evaluate and how to report these changes. In terms of evaluating the response to neoadjuvant chemotherapy, obviously, we can evaluate clinically, we can do imaging methods, and even though these are all are used in the clinic, histopathologic evaluation is the gold standard, because both clinical and imaging evaluation can be imprecise, both as a false negative and false positive. False negative rate of clinical and imaging methods based on what type of imaging method is used can be up to 60%, and false positivity is 22 to 30%. So histopathologic evaluation of these specimens is the gold standard, and obviously trying to develop methodologies which are non-invasive to evaluate responses to neoadjuvant chemotherapy is an area of major research. Pathologic responses can be classified as into different categories. Pathologic complete response or PCR is defined as a complete absence of invasive carcinoma in the breast and no residual metastatic carcinoma in the lymph nodes. And it's very important to understand this definition to compare different studies, because some studies and in some centers and in some protocols, pathologic complete response is defined as absence of invasive carcinoma in the breast without counting the lymph node response. So in general, protocols that incorporate this definition, they have a lower complete pathologic response rate. But it is very important to know how the pathologic complete response is defined. Pathologic complete response occur 5 to 30% of patients in general with locally advanced breast carcinoma after neoadjuvant chemotherapy. With targeted therapies, especially for HER2-positive tumor, now this 30% is approximately 40 to 50% in some series. So it's really important to know how the complete pathologic response is defined. Partial response is defined as less than a complete response. And because of that partial response, it constitutes a wide range of responses. And there are different classification systems to evaluate this partial response. Tumors sometimes shrink concentrically. So if we have a tumor like this, sometimes it just shrinks concentrically as a single mass. So this would be the fibrous tumor area, and this would be in this diagram the residual carcinoma. So if we start a tumor on MRI like this, a single focus shrinks down like this and shrinks down like this. So if we have a tumor like this, the measurement and the evaluation is quite easy because we can measure this tumor both on imaging and histologic evaluation, and that would be the residual invasive carcinoma size. But more frequently, what happens is that what we call a scattered pattern. We start a tumor like this. The entire tumor bed still remains the same, but then residual foci of tumors stay in that area. So not the whole area is tumor, but these residual foci. And then with more chemotherapy, the individual foci may become smaller, but the area involved is actually the same size. So how do we report this, and what is the significance of this is really very important, and we don't have a definitive answer for this. So if there is a single lesion on pretreatment imaging, then the residual disease as a single tumor, this is the easy part, we just measure it. If you look at the 7th edition of AJCC, it recommends largest contiguous area of the tumor. In this diagram, for example, if we have multiple foci of invasive carcinoma, AJCC system is recommending measuring this and giving this as the tumor size. We in MD Anderson disagree with this definition because if you have foci of residual carcinoma in a smaller area, but including a larger area, that has to be also counted, especially for surgical removal, we would like to remove all the residual invasive carcinoma. So this is one of the shortcomings of AJCC system, and actually we are trying to change this definition. But currently, if you are going to strictly go with AJCC system, this is what is recommended. All the important prognostic parameters in breast carcinoma without chemotherapy is also important patients who are receiving neoadjuvant chemotherapy. So the nodal status is the most important prognostic factor of invasive carcinoma. That is also true for patients who receive neoadjuvant chemotherapy. So patients who receive neoadjuvant chemotherapy, number of lymph nodes with metastatic carcinoma is the most important predictor factor. Patients who have no lymph node positivity and 0, they have the best prognostic category. And with each positive lymph node, there is a decrease in prognosis. So the lymph nodes should be examined as carefully as we do for patients without chemotherapy. And after neoadjuvant chemotherapy, lymph nodes are difficult to find, so it makes more difficult job for pathologists, but we have to find all these lymph nodes and evaluate them carefully. Just like in the main tumor, there are histologic changes in the lymph nodes, and we have to be very familiar with these changes. As I indicated before, different systems evaluate neoadjuvant chemotherapy differently. NSABP evaluates only the primary tumor without the lymph nodes. So that's the reason we think the lymph node status should be evaluated. So what we do in MD Anderson, we call it residual cancer burden system, where we measure the residual primary tumor in 2 dimensions grossly, and then we look at the cellularity of the tumor. And then we look at the number of lymph nodes positive and the largest size of the lymph node metastasis. So based on this, we classified patients into residual cancer burden 1, 2, and 3, and then we report this. And this system has been shown to predict the patient's outcome either with Taxol or without Taxol treatment, and in all molecular subtypes of breast carcinoma, including HER2 positive tumors. So in summary, all prognostic factors are important before treatment, are also important after treatment. Residual tumor size and the pattern, lymphovascular invasion, lymph node status. In general, we don't give histologic grade after neoadjuvant chemotherapy, but if there is a major difference, it should be included. And tumor biomarkers, we would prefer to perform tumor biomarkers on pre-chemotherapy corneal biopsy. But if there is a major change in histology, this can be repeated. Thank you very much for your attention.